This chapter is going to talk about disorders of brain function. So some of the major things that we look at is how hypoxia and ischemia affects brain function. Hypoxia causes ATP depletion, or basically a power failure. So if you remember back to when we were studying the cells, when you're in an aerobic metabolism, the cells produce more ATP, or power for that cell to function on. When we're in a anaerobic metabolism, not as many ATPs are produced. So with hypoxia, not as much ATP is produced, and so we end up with not enough power to function the cells of the brain. In addition, sodium and potassium ATPase cannot run fast enough because the ATP has not been produced. The intracellular sodium increases, and that causes the cells to swell up with water. Remember, whichever side has more sodium in it is going to be pulling the water across the membrane. So the cells swell up with water, and that causes lysis of the cells related to the hypoxia. Anaerobic metabolism is also being used, which results in lactic acid being produced. So remember, hypoxia results with decreased oxygen with plenty of blood flow. But ischemia, we have decreased or interrupted blood flow, which means there's no oxygen or glucose going to the cells. The consequences of ischemia is that there's decreased delivery of energy or glucose to the cells. It also results in damage to the blood vessels. So we get a vasomotor paralysis and vasoconstriction. We also see changes in the blood. We have desaturations because, again, we don't have oxygen going to the cells. We also get clotting and sludging of the blood. This question should be pretty obvious for you. Which two substances are needed by the mitochondria in order to produce ATP? Oxygen and CO2, glucose and O2, glucose and fatty acids, or proteins and monosaccharides. Well, in order to have ATP, we have to have oxygen available, but we also need glucose available. So B is only good choice for this answer. When there is brain edema, we have vasogenic or extracellular fluid being present. The effects of the acute glutamate toxicity may be reversible if excess glutamate can be removed or its effects can be blocked before the full cascade progresses. The vasogenic edema occurs with conditions that impair the function of the blood-brain barrier and allows for transfer of water and protein from the vascular into the interstitial spaces. Vasogenic edema occurs primarily in the white matter of the brain, possibly because the white matter is more compliant than the gray matter. Vasogenic edema can result in displacement of a cerebral hemisphere and various types of brain herniation. So in other words, it can move the brain from where it's supposed to be placed into another area. The functional manifestations of vasogenic edema include focal neurologic defects, disturbances in consciousness, and severe intracranial hypertension. The cytotoxic or intracellular fluid involves an increase in this intracellular fluid that can result from a hypoosmotic states like water intoxication or severe ischemia that impairs the function of the sodium-potassium membrane pumps. Ischemia also results in the inadequate removal of anaerobic metabolic products like lactic acid, and it produces extracellular acidosis. If blood flow is reduced to low levels for extended periods or to extremely low levels for even just a few minutes, cellular edema can cause the cell membrane to rupture, allowing the escape of intracellular contents into the surrounding extracellular fluid. This leads to damage of the neighboring cells. And the major changes in the cerebral function, like stupor and coma, occur when there is cytotoxic edema. The edema associated with ischemia may be severe enough to produce cerebral infarction with necrosis of brain tissue. Increased intracranial pressure, and intracranial pressure is known as ICP, can be caused because of increased brain tissue, cerebral spinal fluid, or blood in the skull. Increased intracranial pressure is a common pathway for brain injury from various types of insults or agents. What's interesting is there's a compensation that normally takes place within the skull. So if there's increased brain tissue, then either the CSF or the blood in the skull tends to decrease. Or if there's increased CSF, then there'll be a decrease in the brain tissue or in the blood in the skull. So the head itself tries to keep things on an even amount of pressure. When there's a herniation, the brain pushes from the higher pressure regions to lower pressure regions in the skull. And so we often see that as a result of hydrocephalus or other problems that increase the intracranial pressure. So if you look at the top picture, you can see the tentorium and also the falx cerebra. And these are areas where we see the results of the increased pressure, and we see herniation take place. If you look in the middle picture, then you can see how, for instance, increased bleeding in the brain will cause the brain to be misplaced by the bleeding and can ultimately cause herniation of the brain into the brainstem. Hydrocephalus is a progressive enlargement of the ventricular system from increases in CSF. There's two different kinds of hydrocephalus. The communicating hydrocephalus is caused by impaired reabsorption of the CSF from the arachnoid villi into the venous system. So remember how we talked about how the CSF works its way around and ends up going into those sinuses and being absorbed into the CSF, into the vascular system. It can occur if too few villi are formed, or if there's been a post-infection like meningitis scarring occurred in those villi, or if the villi become obstructed with fragments of blood or debris from an infection. Non-communicating or obstructive hydrocephalus occurs when there's obstruction in the ventricular system that prevents the CSF from reaching the arachnoid villi. The cerebral spinal fluid flow can be obstructed due to congenital malformations or tumors that encroach on the vascular system or inflammation or hemorrhage. So if you look at this picture over here, it's not that hydrocephalus doesn't happen with adults, but we see more hydrocephalus in young children. So if you look at this picture, you can see what the normal size and shape of the ventricles are, and then the little lines, dotted lines, are showing the circulation of the CSF. If the ventricles begin to grow, you can see on the picture on the right how large they can become. And as the ventricles enlarge, in children, the sutures aren't fused yet, and so it will cause enlargement of the head. There's also an interesting type of hydrocephalus that we haven't really been hearing about. We've been hearing about it more the last probably 5 years, but really didn't talk about it too much before then. I'm not sure whether we knew about it or not, but we call it normal pressure hydrocephalus. And it's an important type of communicating hydrocephalus that's seen in older adults. And in the normal pressure hydrocephalus, there is ventricular enlargement with compression of the cerebral tissue, but a normal CSF pressure. The signs and symptoms of normal pressure hydrocephalus include things like memory changes, disturbances in gait, and urinary incontinence. Usually these start out pretty mild and gradually get worse. The changes occur so slowly that they can be overlooked by the patient or their family, or they may be attributed to the aging process. And in fact, it's not unusual for these to be thought of that, oh, he's getting dementia. The signs and symptoms of hydrocephalus vary a lot, and they depend on age and how rapidly the hydrocephalus comes on. When it develops in utero or before the cranial sutures of the skull have been fused in infancy, the ventricles expand beyond the point of obstruction, and the cranial sutures separate and the head expands. The fontanelles bulge, and because the skull is able to expand, there's very few signs of increased intracranial pressure. And because it can expand, intelligence is spared. However, it's not uncommon for seizures to happen, and in severe cases there may be optic nerve atrophy that leads to blindness. Often there's weakness and uncoordinated movements, and usually what's done is that a shunt is placed surgically to allow for the CSF to be removed and prevent the extreme enlargement of the head and the neurologic deficits associated with it. When I was in my bachelor's program, they took us to the mental health hospital, and there was a child there that had not had their hydrocephalus taken care of. And this child's head literally was about 2 feet high and about 18 inches wide. And because she could only lay from side to side because of her head being so enlarged, her head was probably about 6 inches wide from side to side. Just a huge, 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 huge head. I really have not seen anything that large since that. And they really could not go in and put a shunt at this point with the head being so large, because it would actually cause removal of that much fluid would cause herniation of her brain. In adults and children that have their cranial sutures already fused, the head enlargement doesn't happen because it can't. And so with acute onset hydrocephalus, it's usually marked by symptoms of increased intracranial pressure like headache, vomiting, papillary edema, or deviations of the eye. So basically, if you look at the retina, you'll see edema of in the eyes. Often as people have increased intracranial pressure, they'll go into either decorticate or decerebrate posturing. And so if you look at these pictures, the top one is the decorticate posturing. And so what we see is that the feet, not only are the toes pointing, but they're actually almost curving around to put a plantar flexion there. And if you look at the legs, they are internally rotated, and the arms are flexed, and everything about the body is flexed and abducted. So if you think about it, think cord, everything is moving towards the center and the cord with decorticate posturing. With decerebrate posturing, we get the plantar is also flexed. The arms are flexed, but they're pronated so that the arms are near the side, and the arms are adducted. So it's moving away. So in other words, cerebrate and cerebral, everything is moving away from the brain. If you think about it that way, it's one of the ways that you can remember the difference between decorticate and decerebrate posturing. Traumatic brain injury can happen in a number of different ways. The term head injury is used to describe all structural damage to the head, including injury to the skull, the brain, or both of them. The leading causes of head injury are motor vehicle accidents, bicycle crashes, battlefield trauma, sports injuries, falls, and assaults. With the acceleration-deceleration injury, the brain that's floating freely in the cerebral spinal fluid is within this rigid confines of the skull. And so when there is blunt force to the head, it causes the brain to accelerate within the skull and then decelerate abruptly when it hits the inner skull surfaces. As the brain strikes the rough surface of the cranial vault, or the skull, the brain tissue, the blood vessels, and the nerve tracts and the other structures are bruised and torn, and it results in contusions and hematoma. The immediate response to the initial injury includes focal lesions and diffuse injuries, and so we say that they've had a concussion. And the secondary injuries involve complicating processes that result from the initial injury, including brain swelling and infection. When we think about these, This is the type of injury that happens with shaken baby syndrome, where these very small vessels inside of the head are actually torn apart by this acceleration deceleration action. With primary injuries, they're due to focal lesions like the contusions and the hemorrhages, and also the diffuse injuries as a result of concussion with diffuse axonal injury. Secondary injuries, like we mentioned before, are due to the brain swelling, whether there's an infection process, or whether there's ischemia related to the original injury. Contusions represent a bruising on the brain surface or a laceration or tearing of the brain tissue. Closed injury contusions are often distributed along the rough, irregular inner surface of the brain and are more likely to occur in the frontal or the temporal lobes, resulting in cognitive and motor deficits. Hematomas, however, result from vascular injury and bleeding. Depending on the anatomic position of the ruptured vessel, bleeding can occur in any of several compartments, including the epidural, the subdural, and the subarachnoid spaces, or into the brain itself, and then we call it an intracerebral hematoma. It usually results from a tear in an artery, most often the middle meningeal, and usually in association with head injury in which the skull is fractured. Because bleeding is arterial, there's rapid expansion of the hematoma and it begins to compress the brain. The epidural hematoma is more common in a young person because the dura is less firmly attached to the skull surface than in an older person. So as a consequence, the dura can be easily separated from the inner surface of the skull, allowing for the hematoma to grow and become very large. A subdural hematoma develops in the area between the dura and the arachnoid. We call it the subdural space. And it usually is a result of a tear in a small bridging veins that connect the veins on the surface of the cortex to the dural sinuses. The bridging veins pass from the Peel vessels through the CSF-filled subarachnoid space, and they penetrate the arachnoid and the dura and empty into the intradural sinuses. These veins are really easy to be snapped in head injury when the brain moves suddenly or in relation to the cranium. A cerebral concussion can be defined as a transient neurogenic dysfunction caused by mechanical forces to the brain. Acceleration and deceleration is the mechanism of the injury, usually due to non-penetrating force like a sudden blow to the head. There may be a momentary loss of consciousness without demonstrable symptoms, except for residual amnesia. Microscopic changes can often be detected in neurons and neuralgia within hours of an injury, but brain imaging is usually negative. Although recovery usually takes place within 24 hours, mild symptoms like headache, irritability, insomnia, and poor concentration and memory may persist for several months after a concussion. This is known as post-concussion syndrome. Treatment, which is largely supportive, includes both physical and mental rest. Once the symptoms have resolved, the person may begin shortened work days with decreased work demands. Students may benefit from short periods of reading and studying with frequent breaks. Athletes are advised to follow a slow, stepwise return to play. The complications of concussion, although rare, are particularly serious. Currently, the clinical and neuropathic consequences of repeated mild head injury are known as chronic traumatic encephalopathy. When we look at the cerebral blood flow and we look specifically at the carotid arteries, we can see how they branch into the ophthalmic arteries, the posterior communicating arteries, the anterior choroidal arteries, and the anterior cerebral arteries, both the medial and superior surfaces on the brain and the frontal lobes. So as we're looking at these, think about some of the things that we've talked about as far as injury to these arteries, but also think about disruption of the blood flow to these arteries in relationship to some of the other disease processes that we're going to be talking about. The middle cerebral arteries supply the lateral surfaces of the brain, the face and arm, motor and sensory cortexes, and the optic radiations and the speech centers. The basilar artery runs up the back of the brain and splits to form the two posterior cerebral arteries. They supply the medulla, the pons, the cerebellum, the midbrain, the occipital lobes, the temporal lobes, and the thalamus. So stroke, or as some people call it, brain attack, is often called that because much of the pathology that's associated with is similar to a heart attack. The incidence of stroke increases with age, and it varies by sex and ethnicity. Men have higher rates in the younger age groups. The women catch up after menopause, and because they live longer. That results in higher death rates due to stroke among women because they're not as healthy at the time that their strokes tend to happen. African Americans have almost twice the risk of first ever strokes as Caucasians. Blood pressure is a powerful determinant of stroke risk, and individuals with a blood pressure less than 120/80 have about half the lifetime risk of stroke compared with persons with hypertension. Heart disease, particularly atrial fibrillation and other conditions, predispose people to clot formations on the wall of the heart or on the valve leaflets, or to paradoxal embolism through right to left shunting, and that predisposes them to a cardioembolotic stroke. Polycythemia, sickle cell disease, especially during sickle cell crisis, and blood disorders that predispose people to clot formation also increase the risk of developing cerebral vessel strokes. During the evolution of a stroke, there's usually a central core of dead or dying cells that are surrounded by an ischemic band or an area of minimally perfused cells called the penumbra. Often these look like a halo, so they'll refer to them as halo cells. Brain cells of the penumbra receive minimal or marginal blood flow. Their metabolic activities become impaired. Although the area undergoes an electrical failure, the structural integrity of the brain cells is maintained. Reversal of the penumbral injury depends on successful and timely return to adequate circulation. The volume of toxic products released by the neighboring dying cells and the degree of cerebral edema, combined with alterations in the local blood flow, have a lot to do with outcomes for people with stroke. If the toxic products result in additional death of cells in the penumbra, the core of dead or dying tissue becomes larger and the volume of surrounding ischemic tissue increases. Thrombi are the most common cause of ischemic strokes, and it usually occurs in atherosclerotic blood vessels. In the cerebral circulation, the atherosclerotic plaques are most commonly found at the arterial bifurcations of the large arteries. Common sites for plaque formation include the origins of the internal carotid and the vertebral arteries, and at the junctions of the basilar and vertebral arteries. Usually thrombotic strokes are seen in older persons, and the frequency are accompanied by evidence of atherosclerotic heart or peripheral arterial disease. The thrombotic stroke is not associated with activity, and it may occur in a person at rest. One thing I want to point out here, because a lot of people get this really confused, is that DVTs do not cause stroke. The only way, there really is not a way that a DVT can cause a stroke. That's because DVTs cause obstruction in the heart. So what happens with it is a DVT comes up, it gets into the atrium, and from the right atrium, it goes into the left atrium, and it goes to the pulmonary circulation. And so there is no way for a DVT ever to get into the circulation of the head. The only time that we get emboli coming into a stroke patient is when that emboli is coming from the heart, whether that's blood or whether it's emboli from endocarditis, but that's how we get emboli coming into the brain from sources other than inside of the brain. The lacunar infarcts are usually small, and usually they're less than 15 millimeters wide. The infarcts are located deep in non-cortical parts of the brain or in the brainstem. The infarcted tissue eventually scars and it leaves a small round cavity or a lacunae, which means lake, and they're thought to result from atherosclerosis and commonly in the settings of chronic hypertension or diabetes. Because of their size and location, the lacunar infarcts usually don't cause any cortical defects. Instead, they produce classic recognizable lacunar syndromes like pure motor hemiplegia or pure sensory hemiplegia or dysarthria with a clumsy hand syndrome. So if you think about it, this is kind of where most of our strokes are happening, because you see this partial, just one side of the body being affected either by their motor actions or sensory, in that they're not able to feel things on that side, or they're not able to hear on one side, or move that part of their body. An embolotic stroke is caused by a moving blood clot that travels from its origin to the brain, and it usually affects the larger proximal cerebral vessels. An emboli often lodges at the bifurcations, and the most frequent site of embolotic strokes is the middle cerebral artery, and that reflects the large territory of this vessel and is positioned at the terminus at the carotid artery. Although most cerebral emboli originate from thrombus in the left heart, they also may originate in the atherosclerotic plaque in carotid arteries or from rheumatic heart disease, atrial fibrillation, recent myocardial infarctions, ventricular aneurysms, and bacterial endocarditis. They are the most frequent fatal stroke is caused by spontaneous rupture of intracerebral vessels. With rupture of the blood vessels, we have what's called a hemorrhagic stroke. And we have hemorrhage into the brain tissue. When that occurs, it results in a focal hematoma and sometimes intraventricular hemorrhage. Edema is often associated with that, compression of the brain contents, and spasms of the adjacent blood vessels. The most common predisposing factors are advancing age and hypertension. A cerebral hemorrhage occurs suddenly, usually when the person is active. So think about the fact that ischemic strokes happen when people aren't active, or that doesn't mean that they can't happen when they are active, but they tend to happen when people are just sitting in a chair, sleeping, something like that. Where the hemorrhagic strokes happen when people are being active. Often vomiting occurs at the onset, and headache is common. Focal symptoms depend on which vessel is involved. The treatment of hemorrhagic strokes focuses on intensive management of the increased arterial and intracranial pressures and prevention of that hematoma expansion. Think about these two patients. Mr. X has core pulmonality, and Mr. Y has a left ventricular aneurysm. So which of them is more likely to have a stroke? So if we look at it, the left ventricular aneurysm increases the risk of a clot developing in the left side of the heart, which can be pumped out from the ventricle into the cerebral arteries. And so that increases that risk of having a stroke. So which of them is more likely to have a pulmonary embolism? And in this case, Mr. X, with his core pulmonality and right-sided failure, is more likely to have a pulmonary embolism. I wanted to talk a little bit here about the fact that I didn't spend much time talking about TIAs, or transient ischemic events. The specific manifestation of a stroke or a TIA are determined by the cerebral artery that is affected, or by the area of brain tissue that is supplied by that vessel, and also by the adequacy of the collateral circulation. So symptoms of a stroke or a TIA always are sudden in onset and focal, and usually are one-sided. The most common symptom is weakness of the face and arm, and sometimes also of the leg. Other frequent stroke symptoms are unilateral numbness, vision loss in one eye or to one side of the body, or the vision losses on one side, language disturbances, which usually is aphasia, slurred speech, which is known as dysarthria, and sudden unexplained imbalance or ataxia. In the event of a TIA, symptoms rapidly resolve spontaneously, usually within minutes, although the underlying mechanisms are the same as for a stroke. It's just that they're smaller and they just don't last as long. As far as diagnosis is concerned, accurate diagnosis of an acute stroke is based on a complete history and thorough physical and neurological examination. A careful history, including documenting previous TIAs, the time of onset and pattern, and how rapid it progressed, the specific focal symptoms, which will help to determine the area in the brain that this happened in, and any coexisting diseases like heart disease or hypertension can help to determine the type of stroke that's involved. And then they also do an MRI to actually see where the stroke has taken place. It's interesting because now hospitals can become stroke certified, and so it can make sure that you get appropriate care from the minute you get to the emergency room right through rehab phases. Stroke care begins with emergency treatment aimed at reversing the evolving ischemic brain injury. Reperfusion techniques including thrombolytic therapy, which is administered either intravenously or intra-arterially by a catheter, and sometimes a catheter-directed mechanical clot disruption or an augmentation of cerebral perfusion pressure are some of the things that we use to help the stroke not have such long-acting sequelae. TPA is one of the major thrombolytic therapies that we use. There's guidelines that are recommended in persons with suspected stroke, and the diagnosis of hemorrhagic stroke has to be excluded through the use of CT scanning before we give TPA. And the TPA needs to be administered within 3 hours of the onset of symptoms, or 4 to 5 hours in some cases. So it's not that we're saying that TPA is going to be infused the second this person comes into the emergency room, but it's going to be important to get this diagnosis and get them into MRI so that we can determine that a stroke is happening and what type of stroke is happening. So an aneurysm in the brain typically takes place in the subarachnoid area. It results in a sudden onset headache with nausea, vomiting, and dizziness. It results in hemorrhage, and so this causes sudden severe headache, neck stiffness, photophobia, vision, and motor problems. An aneurysm, as you recall from talking about it in the cardiac system, is a bulge at the site of a localized weakness in the muscular wall of an arterial vessel. Most cerebral aneurysms are small saccular aneurysms called Berry aneurysms. The incidence of rupture increases with age and occurs most commonly between the ages of 40 and 60. The mortality rate for subarachnoid hemorrhage is high, around 33 to 50%, with the majority of deaths occurring within the first few days of the hemorrhage. Large aneurysms may cause chronic headache, neurologic deficits, or both. And persons with subarachnoid hemorrhage often have a history of atypical headaches occurring days to weeks before the onset of the hemorrhage. And that suggests that there may be a small leak in that aneurysm. These headaches are characterized by sudden onset and often are accompanied by nausea, vomiting, and dizziness. Other manifestations include signs of meningeal irritation like nuchal rigidity. Nuchal rigidity is stiffness of the neck. The nuchal area is the area at the back of the neck by the spine. And photophobia, or light intolerance. And then cranial nerve deficits like diplopia or blurred vision, stroke, focal motor and sensory deficits, cerebral edema, and increased intracranial pressure. There may even be pituitary dysfunctions like diabetes insipidus, which is associated with hyponatremia. Hypertension is a frequent finding in aneurysm cases, and there may be cardiac arrhythmias resulting from a massive release of catecholamines that are triggered by the subarachnoid hemorrhage. The diagnosis of subarachnoid hemorrhage and intracranial aneurysm is made by their clinical presentations, a CT scan, a lumbar puncture, and angiography. The lumbar puncture may reveal the presence of blood in the CSF, whereas the CT will demonstrate the location and the extent of the subarachnoid blood. The best outcomes are achieved when the aneurysm is secured early and prevention of complications are initiated. Patients with mild to no neurologic deficits may undergo a cerebral arteriography and early aneurysm ablation with surgery or endovascular coiling. So in other words, they actually put this coil in there, and with the coil they cauterize that area. These usually are done within 24 to 72 hours. And surgery involves a craniotomy and inserting a specially designed silver clip that's tightened around the neck of the aneurysm. This procedure offers protection from rebleeding and may prevent removal of the hematoma. The use of endovascular techniques like the balloon embolization and the platinum coil electrothrombosis is an alternative to surgery, particularly in the posterior circulation aneurysms, or if the person is a poor candidate for surgery. The complications of aneurysm rupture includes rebleeding. This results in vasospasm of with cerebral ischemia, hydrocephalus, hypothalamic dysfunction, and seizure activity. Rebleeding and vasospasm are the most serious and most difficult to treat. Rebleeding, which usually occurs on the first day after the initial rupture, results in further and usually catastrophic brain deficits. Your book happened to have a little thing about arterial venous malformations, and I really don't want you to spend a lot of time with those. We may mention those when we get into peds, but basically what happens with those is There's a failure in the development of the capillary network in the embryonic brain. And as the child's brain grows, the malformation acquires additional arterial contributions that enlarge to form a big tangled collection of very thin-walled vessels that shunt blood directly from the arterial to the venous circulation. The arteriovenous malformation typically presents before somebody's 40 years of age and affects women and men equally. The rupture of the vessels in the malformation causing a hemorrhagic stroke accounts for approximately 2% of all strokes. A lot of times we see these malformations on fetal ultrasound, and so usually they'll do something about these before somebody gets older. But if they didn't see them as an infant, then they're going to be at risk for a stroke. One of the things that I think is interesting about brain tumors is that for most neoplasms in the body, the term malignant is used to describe the tumor's lack of cell differentiation and its invasive nature and its ability to metastasize. But the term benign and malignant really don't apply to brain tumors in the same sense as they do to tumors in other parts of the body. In the brain, even a well-differentiated and histologically benign tumor may grow and cause death because of its location. Collectively, neurogliomas are of an astrocytic origin and are the most common type of primary brain tumor in adults. And medulloblastomas are the most common type of primary tumors in children. The brain tumors commonly present with symptoms related to a disruption in the neuronal activity, usually seizures or signs of increased intracranial pressure. Usually what we see is progressive headache, nausea, vomiting, drowsiness, and visual abnormalities. There may be focal or sensory deficits and cognitive dysfunction in a child who had normal cognition. The diagnosis of brain tumors relies mainly on MRI, and approximately 75% of people with brain tumors will also have an abnormal EEG, which can indicate an underlying structural lesion that warrants an MRI. Magnetic resonance angiography and CT angiography can be used to distinguish vascular masses from tumors. The three general methods for treating brain tumors are surgery, irradiation, and chemotherapy. Surgery is part of the initial management of virtually all brain tumors, and it establishes the diagnosis and achieves tumor removal in many cases. However, if the degree of removal can be limited by the location of the tumor and how invasive it is. Seizures refer to abnormal excessive nerve firing. A provoked seizure are seizures that happen because of fever, metabolic imbalances, brain injuries like tumors, drug abuse, or vascular lesions. Unprovoked seizures are known as epileptic seizures, and they really don't know what causes these. Epilepsy is characterized by recurrent seizures that are not provoked by other illnesses or circumstances. A convulsion refers specifically to a motor seizure involving the entire body. Focal seizures, they are further defined as without impairment of consciousness or awareness, or with impairment of consciousness or awareness. When it's without impairment, it's usually limited to one hemisphere. There may be involuntary motor movements, somatosensory disturbances like tingling and crawling sensations, or special sensory disturbances like visual, auditory, gustatory, or olfactory phenomena. When abnormal cortical discharge stimulates the autonomic system, you get flushing, tachycardia, diaphoresis, hypo or hypertension, or pupillary changes may be evident. This type of focal seizure may be preceded by an aura, which is a stereotypical warning sign of an impending seizure activity that can be described by the affected person. The aura actually represents a simple partial seizure affecting only a small area of the electrical activity. So in effect, the aura is like a pre-seizure for the big one. With impairment of consciousness or awareness, it can be one hemisphere to another. So it may start on one side and end up on the other side and maybe back again. These type of seizures arise from the temporal lobe and involve impairment of consciousness. The seizure begins in a localized area of the brain, but may progress rapidly to involve both hemispheres. Sometimes they're referred to as psychomotor seizures and are accompanied by automatisms or repetitive non-purposeful activities like lip smacking, grimacing, patting or rubbing clothing. Confusion during the post-ictal period, the period right after the seizure, is common with this type of seizure. Having hallucinations or illusional experiences like deja vu have been reported. There may be overwhelming fear, uncontrolled forced thinking, or a flood of ideas, or a feeling of detachment and depersonalization with these. A person with this type of seizure disorder may be actually misdiagnosed as having a psychiatric disorder. Generalized seizures involve both hemispheres of the brain. Tonic-clonic seizures were formerly called grand mal seizures, and they're the most common of the major motor seizures. They result in muscle contraction and loss of consciousness. Often a patient may experience a sharp tonic contraction of the muscles with an extension of the extremities and then immediate loss of consciousness. They may have incontinence of bladder and bowel. Cyanosis can occur from the contraction of the airways and respiratory muscles. And the tonic phase is followed by a clonic phase, which involves rhythmic bilateral contractions and relaxations of the extremities. At the end of the clonic phase, the person remains unconscious until the RAS begins to function again. This is called the post-ictal phase. The tonic-clonic phases last approximately 60 to 90 seconds. And then one thing I wanted to mention to you all was about the absence seizures. These seizures used to be called petit mal seizures, and what happens with these is they don't have any convulsive events. But what happens is the person who has them will just suddenly go blank. And it's like the lights are on and no one's home. You could put your hand close to their eyes, they won't blink. And they tend to occur only in children, and they tend to go away as the child becomes an adult. Or in some cases, they can evolve into generalized motor seizures. Talking about treatment of seizures, the first rule of treatment is to protect the person from injury during the seizure. The next thing that we want to do is preserve brain function by aborting or preventing the seizure activity and to treat any underlying diseases. Because remember, we can have seizures related to fevers or meningitis. People with epilepsy should be advised to avoid situations that could be dangerous or life-threatening if seizures occur. The management of seizure disorders focuses on the treatment of the underlying condition that cause or contribute to the seizures and avoiding precipitating factors, and suppression of recurrent seizure by prophylactic therapy with anti-epileptic medications, surgery, neurostimulation, and addressing the psychological and social issues behind that go along with this disease. Anti-epileptic drugs act mainly by suppressing repetitive firing of the isolated neurons that act as epileptic foci for seizure activity, or by inhibiting the transmission of electrical impulses involved in seizure activity. Women of childbearing age require special consideration concerning fertility, contraception, and pregnancy. Many of the drugs interact with oral contraceptives, and some affect hormone function or decrease fertility. All women should be advised to take folic acid supplementation. For women with epilepsy who become pregnant, anti-seizure drugs increase the risk for congenital anomalies and other perinatal complications. Carbamazepine, Phenytoin, phenobarbital, primidol, and valproic acid can interfere with vitamin D metabolism and predispose people to osteoporosis. There are surgical ways of treating seizures, as well as use of neurostimulation to prevent seizures. Status epilepticus is seizures that do not stop spontaneously or occur in succession without recovery. Tonic-clonic status epilepticus is a medical emergency, and if not promptly treated, may lead to respiratory failure and death. The treatment is appropriate life support measures and intravenously given diazepam or lorazepam is the first line therapy. Prognosis is related to the underlying cause as well as the durations of the seizures themselves. This abnormal electrical activity in the brain destroys brain cells. And over time, if a person has a lot of seizures, they will have intellectual disabilities. When you combine that with a status epilepticus, you have increased the risk of mental disability happening with the seizures. With dementias, many are associated with abnormal brain inclusions, which means abnormal circulation, and abnormal cells in the brain. I thought this was interesting, your dementia mnemonic that goes with it. The drugs that are used for dementia are drugs with anticholinergic activity. Often there's depression associated with dementia. There can be metabolic involvement like hypothyroidism. Eyes and ears, we often see declining vision and hearing leading to dementia. Normal pressure hydrocephalus, or tumor or other space occupying lesions, or infections like HIV, virus infections, or syphilis, and anemia, specifically B12 or folate deficiency. All of these things are associated with dementia. With Alzheimer's disease, we see neuritic plaques and neurofibrillary tangles and also decreased acetylcholine. The stages of Alzheimer's disease starts with a short-term memory loss. This moves on to the moderate degree of Alzheimer's disease, where you start getting global cognitive impairment, language, spatial relationships, problem solving. The people with Alzheimer's may become depressed, confused, disoriented, lack insight, and are unable to carry on their daily activities. In severe Alzheimer's disease, there's the loss of ability to respond to the environment, and they require total care and are often bedridden. Although Alzheimer's is probably the most well-known form of dementia, there's other type of dementia like vascular dementia that's related to ischemic or hemorrhagic changes in the brain. Frontotemporal dementia comes from atrophy. Wernicke-Korsakoff syndrome is a B12 deficiency, and Huntington disease is an autosomal dominant inheritance that results in dementia.